Hello, good morning, good afternoon, good night, depending on where you're joining us. Thank you for being in this side presentation from the Neonatal Hemodynamics Research Center. We have a very interesting session today. Today, Dr. Nisimov will present dopamine versus norepinephrine for sepsis-related hypotension in preterm neonates. Dr. Nisimov attended medical school at Tel Aviv University and completed his pediatric residency at Shamir Medical Center in Central Israel. He completed his fellowship in neonatal perinatal medicine and his neonatal hemodynamics subspecialty training at Mount Sinai Hospital in Toronto. He recently joined the NICU at Shamir Medical Center as a staff neonatologist and will be developing neonatal hemodynamics program there. We have a fantastic panel for discussion. We have Professor Eugene Dempsey. He's a University College Crook graduate. He completed his postgraduate training in pediatrics in Ireland and later a neonatal fellowship at McGill University Health Center in Montreal. He's the inaugural Horan Chair in Neonatology at University College Cork, a consultant neonatologist at Cork University Maternity Hospital, and he's clinical lead at the Infant Research Center. We will also be joined by Dr. Amish Jain. He works as a staff neonatologist and clinician scientist at Mount Sinai Hospital, and it's an associate professor in pediatrics at the University of Toronto. He completed his medical school in India, pediatric residency in the UK, and both his neonatal and perinatal fellowship and his PhD in cardiovascular physiology at the University of Toronto. And he's also the site director of a targeted neonatal echocardiography program in the NICU at Mount Sinai Hospital. We will also be joined by Dr. Audrey Hebert. She is a clinical assistant professor of pediatrics in the Division of Neonatology at Laval University and staff neonatologist at CHU de Quebec. She completed her pediatric residency training and neonatal perinatal fellowship at University Laval from Quebec and completed formal training in neonatal hemodynamics and TNA at BC Women's Hospital at the Hospital for Sick Children in Toronto. She also obtained her master's degree health sciences at the University of British Columbia. And for moderating the session, I will be joined by Dr. Tina Leon, who you all know. She's an associate professor of pediatrics at Columbia University Medical Center and neonatal perinatal medicine training program director, New York Presbyterian Hospital. So Dr. Nisimov, please start your presentation.
Thank you very much. Let me share my screen. Can you see my slide? Can you see my slide?
Yes, we can.
Okay, perfect. So thank you very much for this kind introduction. Thank you for inviting me to give this talk. It is an absolute honor, obviously. And with your permission, I'd like to jump right in and talk about the management of sepsis-related hypotension in preterm infants. First of all, I have no conflict of interest to disclose. So for the talk I outlined, during this talk, I'll try to define the problem that is sepsis in preterm infants. I'll discuss the current literature and pinpoint some of the knowledge gaps that we still have. I'll present our work at Mount Sinai Hospital and Sunnybrook Health Systems, and I'll briefly go over what we think is the logical next step in preterm infant sepsis management research. So first of all, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. And shock is defined as an imbalance between oxygen delivery and oxygen demand in the tissues, leading to tissue hypoxia, which significantly increases mortality. Obviously, both of those definitions are taken from not from the neonatal population. It's taken from the third international consensus definition for sepsis and septic shock, which was published in JAMA in 2016. But in newborns, sepsis is usually used to define any infant with bloodstream infection, and shock is a term usually reserved for hypotensive patients. So despite this quote that we see here, from Wien et al. In a publication in 2010, specific definitions are still lacking. So can we define hypotension? We don't have a clear definition for sepsis or septic shock, but maybe we have a clear definition for hypotension. And the short answer is no. We have multiple definitions for hypotension in this age group, none of which is ideal. Mean blood pressure lower than gestational age in weeks is likely the most commonly used. It is based on an expert opinion and was first published in an audit for better practice in the management of RDS. The nomogram that is based on a relatively small sample size of less than 400 babies with gestational age of 22 to 32, not many of which were extreme preterms, and the measurements were only taken once a day and non-invasively. A mean of 30 millimeters mercury is derived from the hypothesis that autoregulation is impaired when blood pressure drops below that point, and that the cerebral blood flow becomes pressure passive, and a significant drop from baseline along with signs of circulatory insufficiency such as oliguria, acidosis, high lactate, or lower NIRS is another emerging definition. Those are some of the more common definitions. There are more, obviously, for hypotension with regards to sepsis. And now I'd like to ask Laura to upload our first poll. And the questions that we are going to ask the audience is, how do you define hypotension at your hospital? We'll give you a minute. Okay, so yeah, as figured, we can see that the answers are all across the board. Some named others. Would be interesting to see what specifically they meant. Sepsis is a significant complication among preterm infants, obviously, with an incidence of up to 35% in extremely preterm infants and an overall mortality of 20%. Up to 20% of preterm infants with sepsis develop circulatory insufficiency, warranting institution of vasoactive medication. And for that subset of patients, the mortality is particularly high at around 40%. Importantly, unlike many other diseases, the prognosis of infants who develop sepsis has remained stagnant over the last few decades. So we have established that sepsis is a common and deadly disease, and that we are probably not getting any better at treating it. So how do we treat it? So the management revolves around early recognition, prompt antibiotics administration, source control if needed, and hemodynamic support in the form of fluid resuscitation and vasoactive agents, again, if needed. Similar to adults, the physiological studies have shown vasodilatory state to be the predominant pathophysiology in preterm infants with sepsis, characterized by high cardiac output, low systemic vascular resistance, justifying the use of vasopressors to treat sepsis-related hypotension. And due to the significant morbidity and contribution to mortality and morbidity across all age groups, international guidelines for the management of sepsis were established. In adults, we know that the Surviving Sepsis Campaign strongly recommends the use of norepinephrine as the first-line agent, as it was shown to reduce mortality and treatment-associated arrhythmia. The pediatric iteration of the Surviving Sepsis Campaign recommends either norepinephrine or epinephrine as first-line agents, but deemed the recommendation weak as it was primarily based on expert consensus and data from adults. Nevertheless, the Surviving Sepsis Campaign guidelines categorically state that preterm neonates under the age of 37 weeks are kept out of the scope of their recommendation, so we are left with no current guidelines. The evidence in preterm infants, so what do we know about it? The trial data is very restricted. There's only one small pilot trial comparing dopamine to epinephrine. This trial had 18 preterm infants with a gestational age of less than 31 weeks and a very high mortality at 70% in the epinephrine group and 80% in the dopamine group. They concluded that both interventions had comparable efficacy. Other than this RCT, we had a few uncontrolled, non-comparative case series showing the ability of pressors such as dopamine, norepinephrine, and vasopressin to increase blood pressure, but unable to provide data regarding their relative clinical impact. What is the current consensus? Dopamine is the most commonly used vasoactive agent to treat low blood pressure in the NICU in preterm infants, irrespective of the underlying etiology. And recently, presumably driven by guidelines published for adults and pediatric patients, case series describing the use of norepinephrine for sepsis-related hypotension in preterm infants have emerged. In 2016, Rocliffe et al. Reported on 48 preterm infants who received norepinephrine. 2/3 of those infants had sepsis, and he concluded that norepinephrine increases blood pressure and is tolerated safely. In 2018, Rizek et al. Published a case series of 30 preterm infants with sepsis who had refractory hypotension and received norepinephrine. They showed an improvement in mean blood pressure, urine output, and oxygenation. While the impact of norepinephrine on clinical outcomes in comparison to dopamine is not known, some centers, such as Sinai and Sunnybrook hospitals in Toronto, started using norepinephrine as first-line agent, which offered us a unique opportunity to historically compare the two agents. At this point, I'd like to ask Laura to load the second poll, if it's possible. Thank you, Laura. And our question is, which vasopressors is considered the first-line agent at your hospital? So we can see that dopamine is still the most common agent. Hopefully within the next few years, we will see a change in that pattern, and I'll try to explain why. So is dopamine our best bet? So there are several physiologic reasons to prefer norepinephrine. First, dopamine has an unpredictable effect on the pulmonary vascular resistance and may increase the PVR to SVR ratio, which in turn can worsen oxygenation difficulties, whereas norepinephrine may promote pulmonary vasodilation or at least decrease the PVR to SVR ratio. 2, dopamine stimulates the release of norepinephrine from peripheral sympathetic nerve endings. However, the ability of dopamine to increase norepinephrine secretion in preterm infants may be impaired due to depletion of their stores. Third, dopamine may be associated with impaired cerebral autoregulation. And fourth, the clearance of dopamine is dependent upon the gestational age of the child, which may be significantly decreased in unwell preterm infants. On top of that, we do know that current literature in adults have shown that norepinephrine is a better alternative. So with all of that in mind, it brings us to our study, which is titled Dopamine or Norepinephrine for Hypertension Associated with Sepsis in Preterm Infants. Our objective was to compare the effectiveness of dopamine versus norepinephrine as first-line therapy for sepsis-related hypotension in preterm infants. Our design and patient selection, so this was a retrospective cohort study, was conducted at 2 tertiary NICUs in Toronto, Mount Sinai Hospital and Sunnybrook Health Sciences Center, over a 10-year period between January 2010 and December 2019. Our inclusion criteria were postmenstrual age of less than 35 weeks at birth, diagnosis of sepsis, defined as positive blood or CSF culture, or culture negative infection treated with IV antibiotics for at least 5 days, or necrotizing enterocolitis stage 2A or above. Treatment with vasoactive agent was another inclusion criteria, and the included episode had to be the first critical illness during the NICU stay, defined as no other exposure to inhaled nitric oxide or other vasoactive agents before this episode. Our exclusion criteria were known congenital, chromosomal, or cardiac anomalies, first-line use of vasoactive agent other than dopamine or norepinephrine, and total treatment duration of less than 4 hours in the absence of mortality. For outcomes, the primary outcome was episode-related mortality, defined as death within 7 days of treatment initiation. And our secondary outcomes were 1, pre-discharge mortality, and it's composite with chronic lung disease and severe neurological injury, defined as IVH grade 3 or above, and PVL. And other episode-related outcomes, such as second-line vasoactive agent and total duration of vasoactive treatment among survivors. Also, we looked at post-episode outcomes, such as new subsequent occurrence of neck or sepsis and severe neurological injury among survivors. Typically, hypotension was defined as mean blood pressure less than gestational age in weeks at the time of the acute event, and vasopressors were initiated when it was perceived to be secondary to vasodilatory physiology, which remained unresolved after fluid therapy, which was typically given at volumes of 10 to 20 cc's per kilo. Dopamine was initiated at a dose of 5 mics per kilo per minute and increased by 5 up to a maximum of 15 to 20 mics per kilo per minute. And norepinephrine was typically initiated at a dose of 0.05 mics per kilo per minute and increased by the same increment of 0.05 up to a maximum of 0.3 to 0.4 mics per kilo. To determine the association, we implemented the inverse probability of treatment weighting using propensity score method. In contrast to matching treated and untreated individuals on a select group of confounders, the inverse probability of treatment weighting approach uses the entire cohort and can address a very large number of confounding variables. Each individual in the cohort is assigned a weight based on the likelihood that they would be exposed to the treatment effect under investigation, and applying this weight then when conducting the statistical test or regression models reduces the impact of confounders. In this figure right here, you can see that implemented weight estimation successfully balanced the two groups making them comparable for further analysis. The gray area is the area that we were acceptable of. A total of 156 preterm infants were included in the analysis, 113 of them in the dopamine group and 43 in the norepinephrine group. The mean gestational age at birth and the treatment for the dopamine and norepinephrine group was 25.8 versus 25.2 and 27.7 versus 27.1 respectively. The mean starting dose for dopamine and norepinephrine were 7.17 and 0.06 mics per kilo per minute respectively. On intergroup comparison, the majority of baseline characteristics were similar, except norepinephrine infants were more likely to have received perinatal treatment with magnesium sulfate for neuroprotection. Looking at the comparison of baseline illness severity markers during the 12 hours prior to treatment initiation, the norepinephrine group had greater highest mean airway pressure and fraction of inspired oxygen needs, as well as higher maximum heart rate recorded, implying that this group might have been a sicker group. And on weighted regression analysis, the use of norepinephrine as first-line agent was associated with lower odds of episode-related mortality, which was our primary outcome. Also, pre-discharge mortality was lower, as well as the composite of pre-discharge mortality with severe neurological injury, new subsequent diagnosis of NEC or sepsis, and post-illness new diagnosis of severe neurological injury among survivors. Obviously, our results should be interpreted in the context of some important limitations. One, the typical dosing used in the clinical practice for dopamine and norepinephrine differs in relative potency, as expressed in terms of norepinephrine equivalent doses. According to this validated scale of norepinephrine equivalent, every 5 mics per kilo of dopamine is considered equivalent to 0.05 mics per kilo of norepinephrine. Hence, the common maximal dose of dopamine of 20 mics per kilo per minute equates to 0.2 mics per kilo per minute of norepinephrine. And if you remember from a few slides back, norepinephrine in our study reached a maximal dose of 0.4, which is double the dose of dopamine. Importantly, we have to say that we did not find any differences in the use of additional second-line agents, hydrocortisone, or overall duration of vasoactive drug therapy. Secondly, while we collected and accounted for detailed pre-treatment illness severity data and we did the inverse probability of treatment weighting, we cannot rule out, at least in part, the potential role of aggregate and performance bias because of increased awareness among clinicians. And third, the use of norepinephrine became more prevalent during the later years of this study, which may contribute to the improvement in outcomes. However, as we mentioned before, the mortality related to sepsis has not followed the same secular trend as we see in other diseases across NICU and is thought to have remained stagnant over the last few decades. In conclusion, the primary therapy with norepinephrine may be associated with lower mortality and morbidity than dopamine for preterm infants needing treatment for sepsis-related hypotension. And the next step, which is probably the most interesting part of this talk, is a prospective comparative effectiveness study across Canada that is planned to come out, and perhaps Amish would like to shed some light on this project. Thank you very much.
That was a great presentation. Thank you so much. There was one question that was raised from Jill Kennard. Did your statistical methodology account for the year of sepsis event? As you were just talking about, there's been a natural improvement in preterm care over the last 10 years. And with norepinephrine, the more recent approach, this may be the bias in your analysis. Could you talk about that a little bit more?
Yes, thank you very much for that question. It's a very important question, and one that we tried to address in the study. We did not include the epochs or the year in which the study sepsis occurred, but we do know from several studies that mortality related to sepsis has not changed during the last few decades, and there is actually data from the Canadian Neonatal Network that over the last 5 or 6 years, the mortality remained at around 40% for babies requiring vasoactive support. Amish, if you have something to add, I know you reviewed the literature as well.
Sure. Sorry, I can't start my video because the host had stopped it, apparently. And the host is allowing me now. No, Sagi, you're right. So as far as preterm care is concerned, that's an obvious question that we all had, that the overall mortality of related to each gestational age criteria has improved over the last 10 years, and there is no doubt about that. The question was, within those who actually develop sepsis, has the mortality gone down? And particularly those who have developed sepsis needing inotrope. If you look at that sub-cohort, we extracted Canadian data primarily to actually when we were writing the grant application for the CER studies Sagi mentioned about. And the last 5 years, there's been no change in mortality across Canada. At least 5 years, that's all we extracted. We could have seen more. The mortality of patients who are less than 32 weeks, who are sepsis and needing any inotrope drug, ranged from 35% to 42% in the last 5 years across Canada. And certainly we have not seen any publications from other countries saying that the sepsis need for inotrope and sepsis-related mortality has changed over the years. There have been commentaries about it, that's one area which has really remained stagnant for a long time. The other thing that Sagi, you may want to sort of mention is your actual years. It wasn't really a distribution which was exactly half and half, which is why we didn't account for years. You want to just talk a little bit, show everybody or mention which years were dopamine and which years were norepinephrine? Primarily, how did that change the use?
Yeah, I can find my Excel file in that graph, but actually I can just speak about it. The first norepinephrine patient was in 2017, and then it grew exponentially over the next few years from about 10% of the patient to 30% to 70% to more than 80% of the patient. So it's basically during the last 3 years of the study that we've seen those numbers.
A few of the participants want to know how functional echo or TN echo has influenced your choice in this case of dopamine versus norepinephrine.
Usually the vasopressor of choice starts before the echo is done. If the baby becomes sick in the middle of the night, we usually don't have echo service right on time. So we have the data on which babies had TN echo in the previous 24 hours, and we've analyzed some of it. But that's something that we need to look into and see if there is a difference in numbers between the group. I anticipate that more babies in the later years had a TN echo before treatment, just because it became more prevalent in our unit. Mish?
Yes, again, a very, very interesting and valid sort of critique of the data, which is why this is not a definitive data set for sure. It's just a sort of a beginning of evidence. As Sagi mentioned, the TNE doesn't really dictate which vasopressor to use. I mean, the TNE may be able to help you in decision of whether you need an inotrope versus a vasopressor, is a low SPR state versus a poor contractility state. It doesn't really help you choose which particular vasopressor might be better, unless people who are operating with TNE are more biased towards using norepinephrine. That certainly is a possibility. But as Sagi said, majority of times a TNE use is not at the time of hypotension. The drug is already started, because when somebody gets sick and septic and hypotensive, action has already taken place, and TNE may make the drug change afterwards as we titrate the medication based on TNE results, which is why in this study we were only interested in the ones who got first line. But I think it's a valid point that we should compare what proportion of dopamine versus what proportion of norepinephrine infants got a TNE before treatment. Because we did not include patients who got norepinephrine when it was changed from dopamine after starting. But that's something which is worth exploring, Sagi.
There was a question also about the second drug that would be used. Did any of this change what other drugs were used in these patients?
I think that it's basically mixed. The other drugs that we saw were anywhere between vasopressin, epinephrine. Some will receive milrinone even. A lot of babies received hydrocortisone. We didn't see any change in or any differences in hydrocortisone use between the two groups. But for the others, I think it's, like Ami said, more of a preference of the physician, attending physician, than an actual trend. I didn't see a difference between the groups.
Yeah, I mean, the other drugs were oftentimes not a routine. So what we really wanted to see is the routine first line when the perception of the physicians is a vasodilatory shock, which is the predominant shock pathology that we come across in sepsis. The other drugs were always had an indication bias, because either it was proven by TNE or perceived to have poor cardiac function, and then people will start epinephrine or dopamine. Same for vasopressin. There was a perception of some patients having severe hypoxic respiratory failure and PPHN, along with or pulmonary hypertension, along with sepsis. Then people will choose vasopressin, even if it's not proven. So those drugs were impossible to assess, because they were not for straightforward warm shock physiology, as norepinephrine and dopamine is, or used to be at least.
Regarding trends of vasoactive medication, I know the question if TNE influences the decision. For example, in our unit, we don't have dopamine anymore. We don't buy it because no one uses it. So I want to see what Professor Dempsey's opinion on is there any trend towards a different mixture or approach. I do think that it should be very important to have an hemodynamic consultation prior, but it has been difficult to prove that it works, right?
Daniel, I'll jump in there if you like. So I guess the study we did tried to do a couple of years back was actually trying to stop people using inotropes inappropriately. And some of that was around definition and problems around definition. And we're still left trying to figure out appropriate definitions, I guess. And just in relation to Saji's presentation this evening, I think it's very important that we take things in context. So if you're dealing with a preterm infant in the first 48 hours of life, that's a very different entity to 5 weeks later with necrotizing enterocolitis or 5 weeks later with late onset sepsis. And if you are using a blood pressure parameter that equates to the corrected gestational age at that point in time, you shouldn't be allowed in a neonatal intensive care unit. So that's just my flippant comment in relation to that. But I suppose what I'm trying to get at is there's a lot more things you need to take into consideration prior to commencing something beyond that time window when we're dealing with a different causative entity, I guess. And echo is a very important parameter that might come into play in that decision-making process. Do we routinely use echo beyond that window, or actually within that window, to decide? Routinely would be an exaggeration, because not all of my colleagues are trained in echo. Do I use it? I will sometimes use it to help my decision-making. But if I'm going to use it, it's often to stop me from starting something. So I think the context of the problem is really critical. And I think defining it, and I think, Sajid, you mentioned that at the start, difficulties defining sepsis, difficulties defining blood pressure problems. And I think as a whole, even though what you presented was really, really, I think it's really interesting and really thought-provoking, you've got two factors and you've got retrospective data collection. And you can play around with statistics a lot, but there are so many factors within that influence people's decision-making that we don't account for or can't account for retrospectively. So I'm really excited to hear Amish talk about the future work that's going to happen, and perhaps you might elaborate for a few minutes and tell us what your plans are.
Yeah, thank you, Eugene. I do actually have to thank you for the HIP trial and the what you published from there, because I did leverage that experience of yours, and I actually pick your brain on the conferences that we met to try and convince the granting agencies the difficulty in doing a patient level RCT in a population like this, which would be the gold standard, really. I mean, if you could, but imagining you're struggling with the HIP trial, even though it was in transition when the parents were available, to this patient population is actually quite sick. It's going to be impossible. So we I have to acknowledge Prakesh Shah, who's worked with me on this particular project. We came up with the idea of trying to do a comparative effectiveness research, because we thought that was the best way to answer this question in a real world setting in a feasible way. So what we did, and what Sagi presented, really was the pilot work for that grant. So it is by no means definitive, and I completely agree with all the things that you're saying, that no matter how much data you collect, the intent and the consideration which went through people's mind at the time point of deciding their therapy, it's impossible to account for. And so is the trends over time. And there are other illness severity markers which you don't get from laboratory or physiological data that might be at play. So we certainly cannot say that for sure one is superior to other by any means. But it certainly raises the point that just like in adult medicine, is it worth comparing the two? And so we can find something. So what we tried to do was we basically sampled the entire Canadian NICUs, and luckily we found that 7 units were actually using norepinephrine already as a routine first-line agent for sepsis-associated hypertension, and another 8 were using dopamine. And if you look at the number of babies they account for a year, it actually comes out to be very, very similar. Then there was a bunch of negotiations and conversations that happened across the country, where we managed to standardize the management algorithm in exactly the same way as you would do in a randomized controlled trial. And so the dopamine units actually agree to start with 5 mics, then go up to 10 mics, and go up to 15 mics in same increments over a same time period, say if the patient still remains hypotensive as they perceived. And then norepinephrine will be doing 0.05, 0.1, 0.15, which is exactly the equivalent doses that the adult use in their trials. And the idea is that over a 4-year period, the unit will standardize their practices, remove the intra-unit variability, remove the indication bias and selection bias from the physicians, just standardize the management practice for the first 45 minutes of these drugs in patients who are hypotensive. And we prospectively collect that data and collect very detailed illness severity data across the country. And then hopefully 4 years later, we'll be able to what we call as emulate a clinical trial by adjusting these markers and then do a direct head-to-head comparison of dopamine versus norepinephrine, when the intent was to use that as a first line for vasodilatory shock. So that's what we have just started. This project started this year in July across Canada, and hopefully, but it will take at least 4 years to get about 550 patients that we are interested in to do a comparison.
That sounds great. Did you think of potentially doing a cluster randomized trial where maybe after 2 years the opposite would happen at each institution and have the other as a second line agent? Or
see, we did. It was impossible to convince people to change the practice they're already married to. Dopamine units will not do anything else but dopamine, and norepinephrine will not do anything else but norepinephrine. So there was just no intra-unit equipoise to actually do a crossover from one drug to another drug. And the best compromise we found was even getting them to agree to a standardized dosing, because they had to give and take a little bit. Some units were actually doing 5 mics, 7.5 mics, 10 mics, and then 12.5. Others were going all the way to 20 mics, and same with norepinephrine. It took a lot of conversations and convincing, and for them to just reach the point of tweaking their practice such a way that at least is comparable across units. But that certainly is a great idea. If units are there, and do a crossover, it certainly do a cluster crossover trial. That can also work if there's equipoise in the unit.
that's great.
There's a question that I think might be interesting for the panel to consider about the use of vasopressors and hydrocortisone at the same time for septic shock. Do any of you feel like commenting about that?
Like, you want to talk about that?
Sure. So basically, we know from the Surviving Sepsis campaign in adults and peds that for catecholamine resistant shock, we use hydrocortisone as a second line agent. We use that also in the neonatal population, both for catecholamine resistant shock, and sometimes they also have Addisonian crisis or adrenal insufficiency as well. At our unit, we used the sample cortisol usually before we started it, just to know where we stand. It's basically, it's a random cortisol, so it didn't tell us a lot, but if it was low in the context of sepsis, then we knew that the kid could benefit from hydrocortisone. The use was about 20% in both groups. We didn't have differences between the groups, nor differences over time with the use of hydrocortisone. The doses that we use at our unit is 0.5 milligram per kilogram 4 times a day. Yeah, anything else that you want to add for that?
Does anybody else want to address the issue? But I think the question was, what do you recommend?
I don't think we have a recommendation like straightforward, but I think I agree. We use it the same. We use it if it's refractory shock, if we cannot wean vasopressor. We don't do a sample cortisol every time. Sometimes we do it, but I feel like we don't really know what to do with the number. I don't think we know in preterm infants what a normal cortisol level is. But it's an interesting use. I think we need to be careful though not to use it. I think there's interesting work from especially the Stanford team about using hydrocortisone. Like if you don't need it long term, then just like any other medication, wean it and just don't use it for many hours if you don't need it. We usually will prescribe it for 24 hours and then we'll reevaluate if we still need to use it. But we don't have a specific guidelines for that, and I'm not aware of anything published. And yeah.
Another question regarding norepinephrine use. It's animal data, right? But it's supposed to be affecting also pulmonary vascular resistance if you're in hypoxemic respiratory failure with high FiO2. Is that a concern in your unit? If you have a baby in 100% oxygen, do you reconsider, or have you seen babies decompensating? Because normally we use a lot norepinephrine because we think it has no effect on pulmonary vascular resistance, right? But is there any, because in the chat there's also a question about vasopressin. So do you use it as a second line agent with norepinephrine, or is there any scenario where you stop norepi and you start vaso? I
actually will be interested in finding from Eugene what they do in Ireland there with vasopressin. And also with hydrocortisone, do you guys use a lot of hydrocortisone, or is it usually for similarly to most other units where we do it for refractory hypertension?
You mentioned some of the trials where there are challenges in recruiting patients. All you have to do is look at Kirsty Waterberg's attempt recently I think it was over 35 weeks. I'm trying to remember the gestational age. But again, that trial stopped after a couple of years when there was a very, very small number of babies enrolled, and that was hydrocortisone to wean pressors, I think, essentially. So ourselves, I have never prescribed vasopressin, so we don't use it. Our unit doesn't. It's used, I think, in some of the children's ICUs for some of the kids with maybe severe pulmonary hypertension or diaphragm-related issues, I think. But again, I would say the vast majority of the neonatal centers, tertiary centers, are not using, sorry, my lights are going out, are not using vasopressin. We do use corticosteroids, or we do use hydrocortisone, but again, limited usage. And really, it's the context of the problem that we're dealing with when we would decide to use it or not. You know, you can be flippant about this, and I sometimes am, but you know, you're giving potentially toxic agents, and then you're giving one potentially toxic agent to get rid of one potentially toxic agent that you have going already, you know. So I just think one needs to think about what you're trying to achieve, and you know, what is the goal of your therapy at the time. And don't get me wrong, I have prescribed hydrocortisone a number of times, you know, and prescribe it a couple of times a year, probably, predominantly in the setting of very refractory hypotension with small babies in the first couple of days, you know, when you're dealing with a mean blood pressure of 14 and you're on, you know, 2 inotropes at that stage. So we don't use it routinely as a kind of a first line agent ever. We will use it sparingly, I suppose is the best way to put it.
Yeah, no, I agree. I think when we were doing this, preparing for the CER, I actually got to learn a lot of different practices. And there were units I came across where their starting point is hydrocortisone. I'm talking about septic shock, not even the transitional hypertension that you were mentioning, Eugene, because there some people do, but even in septic shock, a lot of units will actually start. There were not a lot, but there were a few units who will start hydrocortisone and vasopressor together, with the intention being that it's a presumed adrenal insufficiency, and the hydrocortisone will take few hours to work. So just to cover those for few hours, they will do. So that does exist in our NICUs, in our culture. Our practice is similar to what you were saying. It's about the context, and really for septic shock, if the etiology is vasodilatation because of inflammation and from endotoxins, then we try and give a pressor rather than hydrocortisone. It's only when we have sort of tried to standardize it that if you have a vasopressor unresponsive hypertension in sepsis, then consider hydrocortisone, or second line agent, sometimes vasopressin, if we are going very high doses of Norepi 0.4, 0.5 and not winning still. That's when we will consider. We do a random cortisol at the time. I agree with Audrey, we don't know what to do with that number. But if it is high, then at least it tells you not to put hydrocortisone. If the cortisol level is already 1000, and that happens sometimes. We have seen cortisol levels of 800, 900 in the context of hypertension, which perhaps indicate an adequate stress response by the patient. And in those cases, it sort of prevents us from giving hydrocortisone and try and vasoconstrict more, rightly or wrongly. But if it's low, then I don't know what to do with it. I agree with you. I mean, it ends up pushing you to actually start hydrocortisone, which you may not have done otherwise, which is why we don't do it early on. We only do it when we already decided that the patient probably will be eligible for hydrocortisone because it's unresponsive to a vasopressor. We were hoping we will learn something from collecting that baseline data. I haven't looked at it yet.
So we actually do use vasopressin quite a lot at your unit. We're hoping to publish well, it's going to be retrospective, but we use it a lot for acute pulmonary hypertension, even for first line. So, I mean, it's not specific to sepsis. Obviously, sepsis baby, preterm infants usually will have some form of acute pulmonary hypertension. We very much avoid dopamine in that setting. We actually avoid dopamine all the time at our unit, but so vasopressin, we've been using it and having great improvement, especially in oxygenation index, FiO2. But again, it's more of an acute pulmonary hypertension. And I agree with Dr. Dempsey. I think it's what's always kind of what's the physiology and what's the goal and purpose of using your selected agents. So, I mean, we do use it when we feel like it's appropriate for the underlying physiology of the patient, but we've been having good improvement in acute pulmonary hypertension.
Yeah, and just on that note, what Daniel was saying, in septic shock, if there is severe hypoxic respiratory failure where it appears to be an acute pulmonary hypertensive crisis in association, then yes, perhaps there are times when we use vasopressin as the primary vasopressor rather than norepinephrine, probably one of the only times. Not knowing though whether it actually needed or not. To answer your question, whether we have seen a deterioration in oxygenation and pulmonary hypertension after starting norepinephrine, the answer would be no. I don't recall anyone. But that could also be because when the kids are on 100% oxygen already, what more deterioration can you clinically see by raising the PVR? And perhaps in cases who clearly have pulmonary hypertension rather than we are not even using it, so maybe that's why. But I certainly have not seen a patient oxygenation worsen dramatically because we started norepinephrine and then improve when we took it off.
Regarding monitoring, question for all the panel, is there any other tool that we should consider besides echo, like NIRS or other forms of calculating oxygen delivery?
Sorry, you mean in terms of selection of patient?
Yeah, and maybe in planning a clinical trial, right? What would be the other parameters other than echo that might be of use for especially for documenting an improvement in patients' condition?
Right. I mean, to be honest, even echo, we did a lot of echoes in the beginning because we were enthusiastic and we were always there at the bedside, as Eugene said. In the context of sepsis and associated hypotension, by far, really a great majority of them are just vasodilatory state, where you almost find the same finding of hyperdynamic heart and either normal or slightly low cardiac output. Occasionally, you see a patient with cardiac dysfunction, very occasionally. But I, after that point, I start finding echoes in the context of sepsis quite boring, to be honest. They all give the same picture. It's only so we don't do echo as a first on the moment we start. If we can, we do. It's not really something we are married to too much. It's only when your first line agent hasn't worked, or if the patient is presenting with features which are not standard, straightforward vasodilatory shock physiology. So if you have, say, a low systolic but high diastolic in the context of sepsis, we'll look at the patient. If it appears to be a cold shock state, we'll definitely scan the patient. Or if there is hypoxic respiratory failure, we're not sure whether this is ARDS versus acute pulmonary hypertensive crisis, we'll scan the patient. But if the diastolic, systolic are both low, warm shock, bounding pulses, and known sepsis, we don't scan those patients anymore for selection of patient. We scan them afterwards if they don't improve. To address your other question, and I will be interested in what Eugene think about NIRS, but it's a holistic assessment, but that really is for patient selection. Who do you think needs circulatory support to ensure adequate oxygen delivery to organs? Who is that patient? It certainly is not purely based on blood pressure, but I'll be very surprised if you tell me that there's an E. coli sepsis who's hypotensive and not in shock. Transitional hypertension does happen. The patient are completely well and they have hypotension. Occasionally with PPHM, we can see that the blood pressure is just mildly soft. But in neck and sepsis, positive blood culture, proper sepsis, when the patients who've been stable for multiple days suddenly drop blood pressure, they're not numerical hypotension. They are pretty much in shock state. What do you use? You use lactate, acidosis, urine output, NIRS. We use a combination of all of them to understand, is the delivery adequate to the organ for performance, because really not one of them is going to be enough on its own. We would be very brave to not treat a hypotension in sepsis.
I think I just want to follow up a little bit, because I was almost going to ask a very similar question, and just focusing it a little bit more on the monitoring of the treatment and how you are looking at brain perfusion, and whether there are, better things that we should be doing, to try to protect the brain, because obviously our, sort of two main concerns are, is the patient going to die? And if they survive, are they going to be, severely injured, especially in the brain? And so any thoughts about how we can do better looking at brain perfusion with any of the tools that we have right now?
Yeah, I mean, look, I'm part of the SafeBoost 3 trial, which hopefully we'll be reporting in the next couple of months, I hope. When you think back to the original trial, SafeBoost 2, and you look at the number of interventions that took place, now albeit this is within the first 48 or 72 hours of life, when you think of the number of interventions that took place that were related to blood pressure related problems, it was very low, as in the percentage of time that you made a change based on something related to blood pressure or duct. I guess in terms of its utilization in the setting of either deciding to intervene for a baby who you think has a problem, or monitoring that intervention thereafter, I think it can be helpful. There are no trials that can tell us for certain that, this is what you need to do. But certainly, in very simple terms, if one has a baby with a relatively low blood pressure and a pretty decent cerebral oxygen saturation, you may be less concerned about that blood pressure at the time, but it's at the time. So you do need to, I think, follow that value over time, and with initiation of therapy as well, potentially follow that value. The problem, I suppose, with NIRS is, I think that I love it, but there are many, many challenges that it presents. And I'm not sure if a focus ultimately on absolute values is the right thing to be doing either, whether it's variations from that, whatever preset value you determine, or whether it's actually processes within that signal that are much more important. There may be parts of the signal that are much more relevant than the actual value. And we're doing some work on that as well at present. But there is some work out there from Topan Austin and Elizabeth Kawai and others looking at measuring cerebral autoregulation at the bedside and being able to follow that in real time as well. And so these things are coming. I don't think they're here yet. I think something that has arrived that people are using and they need to reconsider what they're doing is the use of ICONs, or non-invasive cardiac output monitoring devices, in the neonatal intensive care unit. I think we need to take a step back and maybe read William DeBoot's paper from within the last year, highlighting all the problems and challenges around it. So to go back then, maybe just to answer one question that Daniel had asked initially, I mean, let's not forget that there are really relevant bedside things that we can look at on the monitor. And I would suggest that before you roll out the echo machine or turn on the NICOM or do whatever, have a look at the heart rate for the previous 2 hours or 3 hours or whatever. I mean, these are basic parameters that we should be looking at. And if I look at it and see that, it's been trending up for the last 6 hours, I know that's potentially problematic and I need to do something about it. I don't need to roll out the echo machine. I need to decide, well, actually, do I need to start something here, or what am I going to start? So I think there are important, we're all clinicians. We need to be clinicians. So we evaluate the baby clinically. And that incorporates whatever bedside monitoring device we have, whatever parameters we have from a blood gas machine available to us, the ventilation status as well. Put all those together and then make an informed decision. Don't base your decision on one thing.
Thank you. Thank you so much. And regarding volume, so sorry if I missed that data, but regarding volume, what's the current status? Because in a lot of centers, they won't do Norepi without some volume. What's and as TNE people, we have the notion and the concept that volume is normally not the answer. But how's the volume treatment status in your study? Did babies received, how many babies received volume before?
In both groups, almost all babies received saline bolus of 10 to 20 cc per kilo. So either one bolus or two boluses. We didn't see differences between the groups. In my experience from the last 2 years in Sinai, I cannot recall a single one that did not receive. It's just basically our protocol and the quality improvement initiative that we did with sepsis. Amish, correct me if I'm wrong.
No, you're not wrong, Sagi. You're very right. Again, we're coming back to the population, right? This is well, babies who have become late onset sepsis in the ICU and become hypertension in that relationship. We certainly will give at least one bolus of 10 cc per kg. We don't, beyond that, we don't really prescribe anything. Both in our policy as well as in the study that we are doing, we just mandate that people give at least 10 to 20, at least one bolus, because there is a proportion of babies who will just, blood pressure will just come up and they'll just stabilize and never require inotrope or anything like that after that. And you don't want to miss those small proportion, but we don't have an upper ceiling. Of course, in neck, sometimes you have ongoing fluid loss and people, you need to use more, but typically in our units, I would say 20 is what most clinicians will use before they start inotrope, but it doesn't have to be saline. It could even be blood or blood products sometimes. But it will be quite unusual. The only time is that if the TNE is done and it shows severe cardiac dysfunction in the context of sepsis, then we will not give a fluid bolus simply because of the high end diastolic volume already existing and the cardiac. But those are rare cases. They're not common. Audrey, your side?
Okay, so our side, it's one of the things we've been working on, maybe giving less volume. I feel that clinicians sometimes, and I think it's okay to give at least one bolus of 10 and go up maybe to 20 before starting. Again, you have to go back to physiology and think of what's going on with your patient. I agree with in neck, patients might need more ongoing fluids, but if it's really just sepsis, usually one bolus would be okay, but then I agree that you need to move towards something else. And I agree, you need to look at the patient entirely, not just the echo, the blood pressure, the heart rate, look at the patient like itself, right? Like look at the baby and see, and if the baby responds to volume, that's great. But if not, then I think after one bolus, then you should move to something more appropriate, maybe vasopressor or whatever. If you have an echo, then might need some inotropic support. I mean, if you can have an echo, I think it's good, but if not, then I think you can just kind of look at the baby and try to see what's best in terms of management. So yeah, I agree. One bolus and then reevaluate how your baby responded to volume. And if that didn't change anything, then probably you need to move to something probably more of an agent.
I'll share a experimental clinical bedside thing that Eugene was mentioning about it. I try to mimic sometimes the adult's leg raise test for volume. So in adult medicine, they have the leg raise test to know whether your patient needs more volume or not. In sepsis, they've actually done a randomized controlled trial on that, comparing that versus cap refill time, and found them to be equivalent. So what they will do is, if you are hypotensive, they'll in sepsis, they'll raise your leg. If the blood pressure goes up with that, that means you are volume responsive and they're going to give you volume. If your blood pressure does not go up by raising your leg, that means giving a bolus of fluid in the heart is not changing anything. then they'll not give any more volume and then move on to pressors. So I've sometimes done that, and then I see you when I'm deciding whether to give more volume or not, is to just gently press the liver a little bit and see whether that bolus of IVC fluid is going to change your blood pressure. And if it does, then perhaps your patient is going to be fluid responsive. I mean, what you really want to do is you want to find patients who are fluid responsive versus fluid unresponsive. Because the patient who don't get fluid unresponsive are going to get 20, 30 cc per kg for nothing. And they are going to have then volume overload versus patients who will be.
And it makes them worse, right? There's actually studies in pediatrics. I'm not aware in neonatology, but giving too much fluids to a patient in sepsis actually increases mortality. So you just be careful to, like, volume is a therapy like any other therapies we've been talking about for the past hour. So I think it needs to be careful management and reevaluate if your patient improves with what you're, whatever agent you're giving. You need to reevaluate the patient and see how the patient responds to what you're giving, and that includes volume too.
Yeah.
Those are great points. I want to wish you guys so much luck in this trial that you're doing. I think it's really important, and it's really hard to do a trial like that. And for many reasons it's hard, but some of the things that we're highlighting in this discussion is that each of the patients is different, and sometimes grouping them all together, we wind up not getting the answers we want. But I hope that, that this effort will actually come up with great answers and get us closer to learning more about this topic. I think it's very impressive work that you're doing.
Thank you. Awesome.
Well, thank you so much. It's been a great session. I don't know if you have any concluding thoughts.
I'll invite Eugene to do a concluding thought for us. The senior most one here among us.
No, I guess there was some really interesting discussion happened this evening. I think, Sajid, the presentation you gave was excellent, and it has certainly stimulated discussion and obviously has contributed significantly to the conduct of the future trial that you're about to embark upon. And all I can say is echo what Tina said, and best of luck to you over the next couple of years, and hopefully we will get some answers around optimizing agents for this particular problem.
Thanks.
And it's really reassuring to know we all know as little as each other.
Well, some of us like me know less than some of you like you. Thank you so much, Eugene, for coming on
Not
board.
at all. Thanks for the invite.
Thanks, everyone.
Take care.
Thank
Bye.
you.
Thank you very much.
Thank you.